my goal was today to sort of update you on what's new with B, which isn't a lot, but we're seeing a lot more of it in this country. So the first thing I wanted to do is go over the epidemiology of hepatitis B, because we have a lot more information on this than we used to. Worldwide, at least 2 billion people are exposed to this virus, and depending on the literature you read and the source you read, up to 400 million persons in the world have chronic B. That's over 1 million deaths from cirrhosis every year and 800,000 from liver cancer every year. There are at least 700,000 people in the United States with B, and it could be as high as 2.2 million if you adjust it for foreign-born immigrants coming into the country. When you think about your patients, you want to think about where they're coming from, and are they coming from highly endemic areas for hepatitis B? These patients are at the highest risk of having chronic B and should be screened for it and potentially treated for it. In the United States, this is a list of patients from Asian-born countries, the prevalence in their country of origin, and the prevalence in the United States. What you may see is that the actually carrier rate here in the States is higher because some of these people immigrated before they started vaccination programs in their own country. So their countries are now seeing declines, but that population of patients in the United States still has a higher rate. And some of these are quite high. Up to 18% of Vietnamese will have hepatitis B, 11% from Korea, 17% from China. So you will see a lot of patients that are coming over that should be at least screened. And many of them don't know they have it, or they know they have it, and it's like, well, everybody has it in our country, we don't care. And so it's really important to screen them. What about here in King County? This is the Washington data. And what this is you've seen charts before of the world, the high endemic, medium endemic, low endemic countries. And these are where the immigrants in Washington come from. And these countries, Burma, Eritrea, Ethiopia, and Somalia, Sudan, these are very high endemic areas. And so these patients, when you see them in the clinic, are very high risk of having it. This is King County data. This is how many patients have been screened from varying countries and how many are positive for Hep B. And you look down here, 11% of the Ethiopian population has hepatitis B. I have a huge cadre of Ethiopians, I'm sure you guys see a lot too, with hepatitis B that we're working with, many of whom already have cirrhosis, and many have active disease that needs to be treated. And you have to get the whole family screened and get them educated. So think about that when you see your patients. This is the level of acute Hep B that's been reported in King County since 2006 to 2015. You can kind of see a gradual decline, but we're seeing an uptick in chronic. And again, I think that reflects immigration and patients coming into us from elsewhere. So what does Hep B do? Hep B is not a benign virus. Even patients who are carriers can go on to have pretty significant disease. Hep B, when it becomes chronic, can lead directly to liver cancer. You can develop cirrhosis. You can develop acute liver failure, even without cirrhosis, if there's a flare. Many patients then will go on and die or need liver transplant from this. It's the 6th leading cause of liver transplant right now in the United States. Hep C used to be 1. I think it's been flipped now, right? It's now fatty liver is now number 1. So you'll see Hep C fade out of that, the transplants eventually too, as Charles cures them all. So what about treatment? Does it work? Does it affect outcome? I mean, we want to know that what we're doing has some effect. And we have now some really interesting data that we didn't have 5-10 years ago on treating hepatitis B patients. This is an older study that looked at lamivudine-treated patients compared to patients who were given placebo. And what you see here is this is the patients with disease progression, much worse progression over time compared to those who were treated. So treating those patients slowed their disease progression significantly. This was a study that was published by Zhang in 2015 that looked at transplant-free survival. And you had treated patients who responded in the upper line, which shows that there's clear advantage to treating these patients and getting their virus down to negative. If they were non-responders to treatment, you couldn't drive the virus to undetectable, their outcome was the same as if they were untreated. There's now at least 2 studies, and that's what each of these are, looking at does the liver itself improve. These were biopsy studies looking at the inflammatory activity in the liver. And this was at the baseline, and you can see down here there was about 8% who had very mild disease. When you score liver inflammation, it's 0 to very high when you have severe inflammation. As people were treated, and over 5 years, you can see that this much more advanced inflammation significantly decreased. These patients now, 80% of these patients, probably more like 90-some%, had mild inflammation now compared to what they had before. And the second study shows the same thing. Baseline, very minimal inflammation. Now, this was longer term. This was 5, 6+ years, even longer. So even more patients now had decrease in inflammation. You might think, well, of course, you treated them, the virus went down, so their inflammation went down. What about fibrosis? Have they looked at scarring in the liver? And you actually see a reversal in fibrosis as well. This study both looked at patients who had, down here is the no fibrosis. Here are the cirrhotics, the advanced group, right? Green, red, and blue. And you can see that this group significantly decreased, and the group with more mild disease increased. So these patients had reversal of fibrosis after 5 years of treatment. This study showed the same thing. This was, again, very little fibrosis, much better. Cirrhosis, higher levels, is gone. So you also are seeing an improvement in end-stage disease with these patients. And when we started with lamivudine, Bob could probably tell you too, we started taking people off the transplant list as their virus was responding and they were getting better. And it's, I imagine now it's, you get them and they're treated and you don't need to transplant them anymore because you're showing this improvement. And that's important because when we go over the liver cancer risk, cirrhosis in Hep B is one of the most independent predictors of liver cancer in these patients. So if you can get rid of the cirrhosis, you're doing pretty well. And they've actually shown that. They've looked at this. They looked in Hong Kong. These were all cirrhotics. This was treated, not treated, 26-fold relative hazards ratio, actually, in the controls of developing cirrhosis compared to 13.8. The Taiwan data included patients who did not have cirrhosis, so their risk of hepatocellular carcinoma is less. So you see a little bit less here. But in Japan, again, this was all cirrhotics, and you see the decreased risk of liver cancer. What you also see is it doesn't go to 0. You still have to pay attention to these patients, and you still have to screen them. If we suppress them, is this the same as naturally suppressed disease, patients who develop or become carriers and only have surface antigen? And the answer is no. The body can do it by itself. They have a lower risk of developing a disease of cancer compared to those that we suppress. So I still screen these people based on what the guidelines are, and we'll go over those in a little bit. So who should we treat? Should everyone be treated? Well, the goal of therapy is to suppress the virus to its lowest level. And so you'd ideally like to see no virus in the blood. You'd like to see the E antigen, which is a measure of active replication, convert to E antibody. Ideally, you'd like to see them convert completely, which doesn't happen very often. Have you guys ever seen it? I've never seen it. So everybody's like, no. It's like 0.5 to 1% per year, they quote. And you want to prevent liver damage, progressive disease. You want to see the enzymes normalize, you want to improve histology, you want to prevent disease progression, and now you're seeing regression, and that increases long-term survival. So these are your goals with Hep B, right? Now, what do you not see up here? Cure, cure, cure. We can't cure this virus yet. So there are multiple guidelines with regard to how do you treat patients. The American guidelines, the Asian Pacific guidelines, the European guidelines, they all differ a little bit. And so it can become hard sometimes to take a patient and pick which guideline do I want to use. Sometimes I kind of use them both and put them together. And the AASLD guidelines have simplified things. This last publication that just came out, anyone who's got really high enzymes, doesn't matter what their virus is, you know, and they're E antigen positive, you want to treat. So you can go through these kind of cookie cutter pathways similar to Hep C to decide who you want to treat for your hepatitis B. If they have cirrhosis, you should never stop treatment. Stopping treatment carries the risk of reactivation, and that can lead to an acute liver flare and sometimes death. I've seen several deaths from people who've reactivated, and the cirrhotic liver doesn't tolerate that flare at all. So the current recommendations are you treat these people forever. So I'm always thoughtful about who I start on treatment because they may have to take a lifetime of medication. So in patients with cirrhosis as well, the current recommendations are that you treat them regardless of the DNA level. So if they have 500 copies of DNA, most are recommending that cirrhotics be treated. The Asian Pacific guidelines are a little different. Myron Tong put out guidelines for Asians in America that are different and use some secondary characteristics. So Hep B can be kind of confusing for a lot of patients. So what's available? Well, the pegylated interferons are still available, and entecavir and tenofovir are the treatments of choice. We no longer use talbivudine, adefovir, or lamivudine because of the resistance that the virus develops to those drugs. This is one of the newer things available in hepatitis B is tenofovir alafenamide, which was FDA approved last November. It was a year ago now, a year ago. This was a non-inferiority trial. It has similar results to tenofovir disoproxil, and it's a prodrug. So you can use a lower dose. There's less of the drug in the bloodstream. It had a higher rate of seroconversion from e antigen to e antibody, a higher rate of ALT normalization, and because it's a prodrug and it doesn't convert to tenofovir disoproxil till it gets into the liver, you have improvement in the long-term complications of that drug, which include bone disease and creatinine clearance. And in crossover trials, going from tenofovir disoproxil to TAF, you saw actually even an improvement in creatinine clearance and in bone density for these patients. So my 2 cents is that I'm trying to convert people over to this drug because of this improved profile, in particular patients who have to be on this long term. And it only takes one. I've seen one really bad bone osteomalacia that he had to get rods put in his femurs because his bones got so soft. It's a horrible, horrible complication. What are the current recommendations? Well, you can use pegylated interferon if they have mild disease. Again, using this in patients with cirrhosis or more advanced disease is complicated, so you don't want to use this in patients with advanced disease. Monotherapy with entecavir, tenofovir, either one is recommended. And again, it has a higher barrier to resistance. The virus there's been actually, I don't think any reports of resistance to TDF in the last 6-7 years. So it's been pretty good. They're much more potent, and so again, we don't use these drugs much anymore. Now, the guidelines for both AASLD and the European guidelines recommended that you use entecavir or the newer version of tenofovir over the older version if patients are older, if patients have bone disease, so that they can hopefully get some improvement in their bone disease, and if they have any renal abnormalities, again, because of its side effect profile. They're about the same cost, entecavir or TAF. We're going to run into trouble getting it because on December 15th, the patent runs off of tenofovir disoproxil. And now it's going generic. The pharmaceutical company that's making the generic is already poised. Whether it's going to be significantly cheaper or not, I don't know. But we're going to be fighting with insurance companies to get a non-generic drug over a now available generic. What if they're resistant to lamivudine? You want them on a medication that's going to take care of that, that's not going to have cross-resistance. If they had talbivudine resistance and entecavir resistance, same thing. If they were adefovir resistant, but they'd never seen lamivudine, you can use any. If they were lamivudine resistant, again, use the non-entecavir forms, and it goes on. Multi-drug resistance is complicated. It's when you may need to use combinations. The one thing about treatment in this virus, you do not need combination therapy, single drug. So you don't need to use Truvada with tenofovir and emtricitabine. You don't need to add them unless there's significant issues with resistance. So practice guidelines state you need to follow your carriers. And a healthcare provider should be following these people every 6 months, most likely. That's the interval recommended, although there's not real clear evidence. I usually get labs every 6 months and see them once a year because they're usually pretty healthy people. Treat patients who need to be treated and screen those who are at risk for hepatocellular carcinoma. Now, in all the other liver diseases, that's your cirrhotics. But in hepatitis B, that's a different group. The risk factors for cancer in hepatitis B patients and for progression are your older patients, male, Asian and African ancestry. Africans in particular have an extremely high risk of cancer. And they often present in some of the African countries as men in their 20s with a big mass. And so there's something different about their particular genetics with the virus. If they have a family history of cancer, they're at risk. If they're cirrhotic, if they're co-infected, if they're actively replicating, potentially the genotypes make a difference. I often will test the pre-core and the basal core promoter mutations. Those people are at much higher risk of developing liver cancer, particularly the basal core promoter mutations. And I might screen somebody a little younger if I'm worried about it. They have genotype C and they're male and their family history. Their DNA level, there's clear data that when you drop that DNA level, their risk of cancer goes way down. And if they have the other risks of cancer, right? Diabetes, alcohol, smoking. You see a lot of these patients, you get the virus level to 0 and they still have elevated enzymes. Most of them have fatty liver. And I end up biopsying people because I'm not sure what's going on. And they end up with fatty liver. So you may not see normalization in enzymes in some of them. So the current guidelines for surveillance of patients with Hep B are Asian males over 40 and females over 50. This is when their risk increases the greatest. North African and North American blacks over 20. I'm missing the greater than 20 here. You start screening people, so those Ethiopians who come into you and they have Hep B and they're 25, I start screening them every 6 months for cancer. Individuals with a family history, all cirrhotics, and the current recommendations are an ultrasound every 6 months. They took out the alpha-fetoprotein out of the current recommendations, but I still use it. Do you guys? Yeah. those of us who've been around a while, we still use that because we've caught too many with a high alpha-fetoprotein and not a negative ultrasound, and you move on and look at it. So what about cure for this virus? I think it's a ways off yet. It's a much more complicated virus. than hepatitis C. Hepatitis C wasn't a very smart virus. Unlike HIV and Hep B, it doesn't make any copies that are hidden. Like Hep B hides itself within your own DNA, so it has copies of it that it's squirreled away. So even if you clear it out of the liver cells, cytoplasm, and the blood, it's still in the DNA. So they're now looking at several studies. There's now a couple of studies on looking at the early inhibitors. Can we block entrance? Can we inhibit its translation? Can you modulate the immune system? What about release? If you can't get it out of the cell, then you can't progress. And other core inhibitors, other studies. And there's a lot of stuff. This was probably 50 abstracts at the liver meetings with these early trials, phase 1, phase 2 trials in the lab and in animals, looking at early entry inhibitors, modulators, nucleic protein. There's some very interesting data. Some of them are very encouraging, but it's still extremely early. And with Hep B, will a single agent be enough? If we block it, are we going to block all of them and its entry, or will? And so we just don't know. And so it's a ways off yet for the holy grail of getting that. Because if we could cure this virus worldwide, you'd really make a big impact as well. So in summary, you've got a large population with Hep B, and you need to think about it in your immigrant population. Antiviral therapy now, we've shown that it suppresses the virus, reduces inflammation, reduces and reverses scarring, and it reduces the risk of liver cancer and liver-related deaths. These new agents have similar efficacy, but a much better safety profile, and who knows, there might be a cure somewhere along the horizon. So I'm going to stop there and have you caught up.